Good afternoon, and welcome to Health Leaders The Winning Edge program, a weekly series of webinars touching on the topics and strategies that you need to know most. My name is Eric Wicklund. I'm the Senior Editor for Innovation and Technology here at Health Leaders, and I'm going to serve as your moderator for today's session. Today's webinar is titled The Winning Edge for Defeating Denials. It's sponsored by Waystar. Thank you to our sponsor and to you and our audience for joining us today. Before we get started, I do have some housekeeping details to go through very quickly. Our program will be approximately 60 minutes in length. Note that an on-demand version of this program will be available on our YouTube channel this Friday, and it can be accessed through our website, healthleadersmedia.com. There you will also find a written wrap-up of today's event tomorrow. To ensure that you see all the content for this event, please maximize your event window and be sure to adjust your computer volume settings and or PC speakers for optimal sound quality. Next, you'll find a resources list for today's webinar in the upper right of your screen. Here we've listed the webinar slide deck for you to download along with supplemental resources from our sponsor. Additionally, you'll find a registration link for future The Winning Edge events, and we have one of these every week. At the bottom of this console are multiple widgets that you can use. To submit a question, click on the Q&A widget, and we will have a Q&A session at the tail end of this hour, maybe the last 10 minutes. It may be open already and appear on the left side of your screen. You may submit questions at any time during this presentation. However, please note that it's likely that your questions won't be answered until that Q&A portion of the program. Finally, should you experience any technical difficulties during today's program, and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. Now, at this time, it's my pleasure to introduce our panelists. And at the moment, we have one. We're trying to get dialed in now, so we're a little bit short right now, but that's okay. We're going to go on with this conversation. Beth Carlson is here. She's the VP of Revenue Cycle at WVU Medicine. And Eric Sullivan, Solutions Strategist at Waystar, is also here. Thank you both for joining me today on this panel. And with that, we're going to jump right into the conversation. As I said, as soon as our third panelist comes in, I'll get him into the conversation as well. This is a fascinating topic, one certainly on the minds of every rev cycle executive around the country, and one that we're certainly seeing in the news time and again. And what I want to do with this panel is kind of get beyond the hype that we have heard about social media and so on and so forth, and drill down to how health systems, hospital executives are dealing with denials. Not necessarily that payers are denying claims. I mean, that can be a whole other conversation. But how, when you get that denial, what do you do with it? How you can use technology to kind of prevent denials in the future, and how you can use technology to speed up the denial process towards a better resolution. What I want to start with is just a little bit of a conversation here about yourselves and your organizations. Beth, could you tell me a little bit about WVU Medicine and maybe a little bit about how denials are affecting your organization?
Yes, absolutely. Thank you for having me. WVU Medicine is a health system, a 25-hospital health system across West Virginia, Pennsylvania, Maryland, and Ohio, including an academic medical center. And I oversee all the revenue cycle functions here. And the way that it's impacting us, I would say, is this new shift of such a dependency on clinical resources and strong clinical partnerships and shared accountability there to influence prevention initiatives and drive those results. Previously, really claims management was a revenue cycle bread and butter, but that has noticeably shifted for us to denial management strategies and prevention, where a lot of our attention needs to be there to sustain performance. And it's tricky because it requires a complete strategy shift in your revenue cycle skill set, your capabilities, clinical integration, and that can be challenging for any traditional revenue cycle to reimagine. And it's not a temporary support model that's needed. It's more of an infrastructure that helps ensure that we are fairly reimbursed for medically necessary services that we provide to our patients in good faith. So that's how it's impacting us. I think that revenue cycles are used to targeting outcomes for processes that they don't necessarily own, because we've always been at downstream back-end function, but not like this. This is different now, how our reliance on success is on processes and actions that occur even further up in the patient throughput cycle, where we're not really used to and probably not as comfortable inserting ourselves to make this shift. So.
It's certainly a different environment than you're used to. So, and
Yeah.
that a lot of that is what we're going to get into today. How you work in that environment. How do you work through these changes? Eric, tell us a little bit about Waystar.
Yeah. So again, Eric Sullivan, I'm a solution strategist at Waystar. Waystar is really focused on just simplifying all healthcare payments with end-to-end revenue cycle solutions. From eligibility, authorization, estimation, claims and clearinghouse, all the way through patient payments. Obviously, part of that is really the focus of our discussion today with denial management. So part of the claims focus that we have is really trying to avoid at all possible any denials, but also be able to predict when they might happen, and then give tools and technology to providers to be able to automate things like denial management, sending appeal letters, things like that. So for purposes of today's discussion, that's the portion of what we offer, but everything from end-to-end revenue cycle, patient payments, that's really my focus area. So that all is connected to denial management as well as patient payments overall. So looking forward to the discussion.
Do you see that your clients, your hospitals and health systems, are they being challenged by denials now?
I would say that's a safe bet. I mean, I've heard CFOs and rev cycle leaders a number of times say that of all the things that keep them up at night, it's denials, or maybe one thing they wish they could fix in healthcare today. So no, that's a core focus. Any conference you go to, that's a big topic. Certainly, client conversations we have. Anytime we ask, hey, what are some of the pain points you have in your current processes? A lot of it stems on how we're trying to fix denials. So how to identify those. Knowing that denials throw a big wrench in any revenue cycle. So when a claim gets denied, it's not just about losing that payment. It's potentially all that administrative cost too that has to be put in place to follow up on denials and do all the necessary legwork for that. So I think collectively, yes, it's a big topic, if not one of the main topics that are affecting our clients today for sure.
Yeah, certainly it affects far more than the back end operations as well. It affects patients. It affects providers significantly. Okay, let's talk about let's get a little bit more specific now. Beth, how much do denials affect your revenue cycle? And I know I kind of asked this a minute ago, but are you seeing more of them in recent years, or different kinds of denials?
Yes, we are seeing more, not only in volume, but also in ambiguity and variety and complexity. I think that's a part of what's making it so challenged, where I am really less concerned about how denials are impacting our revenue cycle and more focused on how it really impacts our organization as a whole.
Now, when you talk about ambiguity, what does that mean in terms of denials?
So I think when we have talked about denials previously, when the trends started to increase, there was a lot of talk about trends and monitoring denial increases and reasons and payers, but the trends have really been telling us very little. Every single denial kind of takes on a life of its own, and that's what I think makes it so complex. We can route denials, of course, based on reason or payer or expertise or suspected root cause, but when we really root cause every single denial that we review, there's a lot more ambiguity around what type of skill set it really takes to resolve some of these denials, whether it's, too complex for a billing resource, doesn't necessarily require a clinical license. We're seeing a lot more there where we've actually implemented sort of a triage escalation capability so that we have these going to the right place to get to resolution more timely, because there was a noticeable impact on our performance where these more ambiguous denials were, just kind of getting tossed around among departments, trying to find a place to go for resolution. So that's tricky for us as well.
I see. Is there an estimate as to how much it's costing WVU Medicine, or any way of quantifying how this does affect the health system?
Yeah, we monitor our cost to collect very closely. Denials is actually one reason that we've started monitoring our cost to collect at the account level. So quantifying every single touch on an account, of course, when it gets to some of these denial resources, every single touch becomes more costly. It's a higher level resources that start investigating these. And it's a struggle, I think, for all of us to find that balance between disputing every single denial, appealing cases to the point of earning receiving the reimbursement that we've earned, versus a point of surrender where the efforts and cost and administrative burden on overturning some of these denials really aren't worth some of the reimbursement, especially where a lot of denial activity is high volume, low dollar. Is there more of a bulk appeal approach to address some of these, or are some organizations just simply not able to target any of those low dollar denials, even though the volume of them is impactful to the performance?
I see. Yeah. Okay, Eric, is this industry wide? Are health systems in different stages or facing different problems with denials?
I mean, I think it's definitely industry wide. I mean, as far as what Beth was saying, that all resonates based on what our clients are saying too. So across our entire client base, I think it's a common denominator. We've seen them rise over the years. Again, Beth even mentioned some of the complexity and the different maybe rules that the different payers have. Certainly being able to trend and track all the denials collectively, maybe not just individually, but collectively, to being able to sort out different categories, different payers, maybe the reasons they deny a claim. Is it related to eligibility or prior authorization or medical necessity? All that certainly can report on and be able to track. But I think also being able to use technology to be able to reduce the number of denials up front, and being able to put the tools in front of the staff to be able to make sure the coding is proper. And then if denials do happen, being able to automate the workflows that require for things like appeal letters, all that. I think that's really where the value of technology comes in. And as a patient, I always like to try to make everything personal from a patient standpoint. I've been on the other side of a denial where I had a hospital stay. Unfortunately, I'm okay now, but I had a hospital stay where my payer, my insurance, denied my inpatient stay when I know it was medically necessary. But there's a whole argument back and forth between the payer and the provider, and how I had to provide all the necessary documentation to justify my hospital stay. So there's a lot of anxiety and a lot of fear on a patient standpoint too, that then trickles down into overall patient experience that then flows into the provider too. But so there's a lot going on with denial specifically, but from a client-facing perspective, I think it's industry-wide for sure.
Yeah, and certainly in this area of hyper-vigilant social media, we get to see the stories that show up, and the extreme cases that go on. There was one just this other day about a cancer patient in the middle of the surgery. The doctor was messaged by the payer asking if this was necessary. It becomes a kind of a hype that kind of shines a spotlight on RevCycle to fix the problem, when maybe that's that the hype is a little bit too overbearing. But now that we set the stage, let's talk a little bit more about what health systems are doing about it. Beth, what strategies do you use to determine how and why denials are made?
So we do root cause every single denial write-off. We do a full root cause analysis on each one. As I said, the trends really don't tell the true story. We have service line task forces that review these root causes. Signature service lines, for example, focus areas on infusion, lab, inpatient, neuro, surgical, things like that, to discuss trends and best practices for their services, in particular on the denial activity that we're seeing, especially the things that they can influence. We've also integrated all of our clinical financial resources to consolidated teams. For example, inpatient with utilization review, outpatient appeals with outpatient medical necessity, outpatient off, so that the people that see and work the denials are the same people that own the process where possible, so that we have more insight into what goes into creating the denial, so that we can be more effective in the outcome of that denial.
Now, is there research that goes into tendencies by different payers to issue denials? Do you kind of get an idea of what payers are going to do what denials, or what payers are more likely to issue denials?
Yeah, definitely. We spend a lot of time trying to understand our payer behavior, and that does shift our strategy. For example, we have a payer in particular whose initial denial rate is very high, but their overturn success rate on a level 1 appeal is also very high. So in that case, to me, we approach that as a delay tactic, right? And it's really not so much the quality that goes into your appeal, just the timeliness and occurrence of it. I know some organizations try to pull in provider education into their denial strategies, which of course is important, but we struggle with that a lot, because how much of an expectation and accountability can you really put on a single provider when these payer nuances come into play? I don't think it's reasonable to expect a provider to know when a medically necessary procedure would be appropriate for one patient versus another patient just because of their payer. So we try to configure all of that within the system where we can. So we have teams reviewing payer policies and building order alerts or templates that consider the payer in what the provider is ordering, not necessarily to prevent the order from going through, but maybe to alert for more comment around medical necessity so that we can utilize it in an appeal if needed. So when those payers do at least use a lot of medical policy to support their denial activity, we try to also build that medical policy within our ordering activity so that we could either prevent it when the provider does have other options, or support appeal activity.
Nice. Okay. Yeah, and this is certainly where technology can come into play, particularly AI, and we will get into that in more detail in a little while. Eric, are there different strategies for determining how and why denials are made? Are hospitals and health systems doing different things to address this?
Yeah, I mean, first I'll just echo what Beth said around looking at root cause of the denials, the particular reasons of individual denials certainly is part of it, but more collectively looking at trends and tracking that. So I think it comes into analytics and reporting, having all this source of data, the proper information all gathered together to be able to look at things like if it's a coding mistake, eligibility, missing documentation, a legitimate denial, or is it a delay tactic like Beth was talking about. So those are all things that's important to be able to leverage technology to be able to do all that. And then some payers might even have certain rules that cause a claim to be denied versus another payer that it might go through without medical necessity checks. So all those things kind of play in, but once all the different trends are identified, then you can take steps to really help prevent the denials in the future proactively. And then, making sure codes are more accurate, verifying insurance ahead of time, making sure documentation meets the necessary payer requirements, all from that retrospective analysis. Then you can apply it more in the future. And then on top of finding the root cause, making the resolution process of each denial much easier. So as Beth mentioned, that first pass appeal, if it's more successful for one payer versus another, using that type of data to understand maybe the assets needed or the amount of time needed to appeal one claim versus another, all that goes into data and analytics to be able to do that cost to collect calculation accurately. So I think there's a lot that goes into that, but that's how some of our clients are using it.
Yeah, it certainly sounds that being proactive is a good idea here to get upstream of these denials and try and understand them before they actually take place. Now, with delaying tactics, how do you deal with a delaying tactic? What do you approach the payer and say, hey, we know what you're doing, stop doing it? Or, what can you do to kind of counter a delaying tactic? Beth?
I think the important piece here is the engagement of your payer relations team and making sure that they are at the table when these denials are being disputed or escalated, and the use of a payer scorecard to bring that data to the payer at the right time. Frequent and recurring feedback is kind of what we do through our appeal process, but it doesn't really have as much outcome as bringing that data to negotiation would be, where we use our payer scorecard more so for that to show not only denial rates, denial write-offs, but also administrative effort and utilizing that cost to collect at the account level to quantify cost to collect at the payer level as a result of some of this activity. So I think that's where having your payer relations team as a strong partnership for some of this activity really comes into play. I think some payer relations teams are still kind of in that mindset. If it's a good rate, it's a good payer. But if they're involved in the root cause, the escalation, in the dispute process of some of these high dollar denials, I think it is very insightful for them to understand some of the real behaviors occurring here, and whether some of those rates are really worth it or if there's more to the story for addressing those.
Yeah, I like that. Yeah. It's long been said that payers and providers are kind of at each other's throats almost in healthcare. For so long, they seem to be antagonists. But the idea of using technology and using data to collaborate with them and see it more as a complementary role rather than a combative role. There's certainly a lot of merit there. Eric, same question. Do health systems approach the idea of delaying tactics differently? And are there different strategies for addressing that?
I think Beth covered it from a health systems perspective. I think where we come in is really surfacing the data and the analytics to be able to pinpoint that, because it's such a subjective thing, right? It's not like you can code a claim that it's a delay tactic, right? Now, obviously, input notes and things like that we enable. So our clients obviously are the ones that determine that, but with the tracking and the trending of the analytics, that really helps unlock and pinpoint some of those potential delay tactics. If it's a trend in one particular payer or one particular procedure type, DRG, whatever it might be, that can kind of look and really pinpoint that within analytics and reporting. So that's kind of where we come in. But I think Beth's spot on with what her suggestions were for sure.
Okay. Now let's talk about the technology a little bit. And I know, Beth, we've talked about this a little bit before. The idea of new tech like AI being used to proactively identify and reduce denials. Could you give us some examples of how you're using technology, particularly AI, to address denials?
Yeah, we definitely see this technology and AI as a tool, not a solution. And I think there are specific use cases where this can come into play, but not necessarily across the board for all denials and all denial reasons. One population, for example, is maybe level of care determination and downgrade situations where the model can utilize the clinical criteria within the chart and the documentation in the chart, as well as the 835 data from the payer to determine whether that is likely to be denied at that level of care or downgraded for that DRG. So I think that's a strong case from an inpatient perspective. For outpatient similar with ED downgrades and the clinical criteria where we see a lot of payers doing a lot of ED downgrade activity. I think it could be used for both prevention and appeal. I think a lot of the AI technology is being explored for appeal letters and the content to put in what would make a successful appeal, because you have that overturned data as well to train the model on what can be suggested to put into the appeal that would give it a higher overturn success rate. And then, of course, AI on denial activity for things related to diagnosis codes and medical necessity. We have tried some AI predictive models around that, but we've found that when the rules exist, you can just build it yourself. You don't need a model to train from it when that criteria is simply pulled from a payer policy. For example, we don't need to look at their claims processing activity to configure the policy that we're able to read and configure from. So I think there are definitely some strong use cases, but I don't think it is a broad solution that is going to take away all the efforts that we still need to do around education, prevention, and strategy.
Yeah, certainly the promise of AI so far, at least is that it can crunch the numbers a lot faster than manual processes. Take the data and pull the necessary insights out of that data much quicker, but maybe speed up the process, spot the trends, do everything at a much faster rate so that this whole denial process can be shortened and maybe and fine-tuned. Eric, same question. How's technology, how's AI being used now for denials?
Yeah, I mean, I think Beth said it perfectly with the whole concept that AI is not a fix-all for everything, right? It's not a solution for everything. But when you do find the things like denials and specifically appeal letters as an example, that's immediate applications that AI can really alleviate any administrative or most administrative work from any individual team member at the health system or organization. I think it also comes in, obviously, coding. So coding, when we're looking at a particular procedure or a charge code, doesn't need to have other supporting documentation or other particular modifiers or whatever it might be with coding. That obviously helps reduce the chances of a denial, but I think on the other side of things too, it also helps with revenue capture. So let's say AI analyzes the coding data and says, yeah, you have a high chance of a denial for this particular claim, but we're also identifying potential missing revenue for missing charges. Those types of things also play in with AI too. So there's a lot of different use cases that technology could be leveraged for. Obviously the appeal process, like Beth was already talking to, when a claim does get denied, to generate that appeal letter based on the exact reason for the denial, can make it personalized more readily to really address the specific issue, which makes the process quicker. So you're having less frequency of human error for those tasks that can be automated. But if let's say there's with eligibility or prior authorization, AI can also fit into things like that too. But if there's a clinical decision that AI doesn't have the capability to make, where it needs an actual individual to make that clinical decision and input that information, again, that's where it comes in as well, to be able to mix in AI as well as input from individual team members too. So I mean, all that kind of plays into overall revenue cycle, right? But for denial specifically, I think where you can take the manual work out of that appeal follow-up and things like that. Those are immediate use cases that are set up for AI specifically.
Yeah, let's follow that track a little bit. Is there a process that you would like to see AI address, or technology in general address in the future, that could improve that process, that denials process? Is there something you want to see in the future?
The occurrence of them at all. Yeah, but I think that's one of the biggest flaws for me, especially when we talk about AI for denial prevention. When you really look at how AI models are developed and trained, once the data element that exists that triggers the model to say, yes, this is going to be a denial, the occurrence has already happened. So the denial at that point is not always preventable. So how helpful is that to a revenue cycle to pretty much just know sooner that it's going to be denied? So you have to think about that as well, as whenever the model is able to make the prediction, is it at a point where we can intervene and prevent it, or is it just another method of awareness, really? So I think that's what I'd like to see technology solve, is really the occurrence of them, where, of course, I think a lot of organizations are focusing on the automation side of, appeal volumes and automating appeal responses and things like that. But hopefully our technology solutions and automation and AI can keep up with the payers, because we are seeing that they're able to just handle more volumes than we are. So we have to try to keep up.
Yeah, that's certainly the promise of predictive AI, predictive analytics, is being able to predict and then take action by predicting rather than waiting. And I know we've had this conversation before. Some of these AI tools that are out there now that you've even had experience with, a tool that can identify a payer's potential to create a denial, so that the denial is coming. Well, that's fine, but you want to have the technology to prevent that denial from coming in the first place, rather than having to deal with it. There's a lot of potential there, I guess, in the predictive side of things. Okay, and this is something we kind of touched upon before, but I want to get back into the idea of collaboration. How do you work with payers to improve denial management? Are there opportunities for improved collaboration between providers and payers?
Yeah, I think certain payer relationships with us work better than others. So I think targeting your biggest partnerships is the right way to go about this. So we have maybe 2 recent success stories, I guess I could talk about, in payer relationships with denial management. So one, of course, is our own internal health plan that we had established in 2022, Peak Health, who really wants to do things differently so that the provider of care and the provision of care have an aligned strategy and want to do what's right for the patient. So that's been a great partnership for us to really discuss what policies we should adopt on our side and train our providers on and make sense for the patient, versus how we can utilize the data where we deny less to take this back to our larger payers and say, look, we've tried this and this is the success that we've had, and this is proof that you don't need to have these delay tactics, or does it really impact your savings as much as you think it's worth, especially in scenarios where we have an authorization rate of 99% and they still require us to get auth and deny for no auth. So we also consider that in our contracts, right? Having clauses that say things like, if you would have authorized this as medically necessary at the time of service, then honor it post-service, even if we didn't get the auth and things like that. And some other things, as we've expanded our clinical partnerships and education and task forces and educating on some of these denials, we've had great feedback from some of our providers, and this is another area where having clinical leadership and clinical contribution really makes a big difference when we go to discuss it with the payer in the peer-to-peer, and what are providers really seeing when they are trying to make the best care decisions for these patients. We had some denials occurring because of a policy, and we went to educate the provider on this policy, and the provider not only convinced us, but convinced the payer that it's an outdated policy because of new technology that's available for, there was an eye procedure or something, and the payer actually changed their policy because of what we were able to bring to the table with that provider. And that's just small wins that you have to take when you can, and just educate yourself and your organization about what these policies say and try to get on the right page about what's right for the patient, especially a lot of these policies that we see that contradict best practice protocol, right? Why? So bringing providers to the table to educate on that, to try to tackle them, one policy or one denial at a time.
Now, how do you get providers involved in this process? Is it just an open communications, talking to them occasionally, or do you put together a committee or a forum or a workspace where you can talk about these issues?
Generally, it's a committee more on clinical administration, but we will pull in providers when we see them being specifically impacted by the denial activity, because they are the ones doing a complex procedure, for example, or their ordering practices have a higher denial rate than some other providers. We will pull the provider in to discuss the denial activity. So we have, of course, our physician advisory services too that are more involved on a regular basis on all of our denial activity, and they kind of do that outreach as well to determine when we need to pull the provider in to collaborate further with specific providers. Of course, some providers aren't as engaged, of course, as others. I think everybody sees that with denial activity, but it can really make a big difference. But otherwise, we utilize our physician advisors that still have some level of expertise to be able to contribute at that clinical level and utilize their license to dispute these as well.
Yeah, I imagine their input can be valuable at times. Yeah, and at this time too, when there's so much, workload issues with workloads and stress and so on and so forth, finding the time to do that, finding the time to spend on that is got to be a little bit difficult as well. Eric, the same question. What are some of the new strategies you see that payers and providers are using to work together on denial management?
Yeah, first I'll say about that story about the physician, the peer review that really changed the payer's mind and internally as well. That resonates to me because I feel like anytime there's a clinical decision and a financial decision, if financial outweighs the clinical and the patient's care, that's where we don't want to go there, right? We want to make sure that we're taking care of patients, and providers are able to have the flexibility to be able to prescribe the right medication or treat the patient the way they best see fit. So I think that comes down to, number one, if we have visibility into all the data we've been talking about, right? Being able to track if it's based on a particular procedure, diagnosis, whatever, obviously from an analytics standpoint, being able to have more real-time adjudication and pre-authorization. So the example I mentioned earlier, my personal experience as a patient, where I had a denied claim. Well, they couldn't get a pre-authorization at the time, and that in the time that I needed to be admitted. So my inpatient stay was denied because it wasn't prior authorized. So it's like, part of that makes you think, I know I needed to be admitted because in my situation I had to be admitted. So from a patient's perspective, also being able to have that information readily available, whether it be from the provider or the tools the provider's using or the payer, being able to communicate with the patient the reason that claim was denied, because I was kind of left out there hanging for a while. That I didn't know why my claim was denied. I thought I was going to have to pay it out of pocket, but luckily the provider was in network, so those rules apply. But communication with the patient, that's also important. Yes. Guiding them through the process, whether the claim has been authorized or the claim's been submitted, the claim's been paid, their amount is due now, or if there's a prior authorization that's needed, all that. Just keeping the patient informed throughout the process is important for sure.
Yeah, sometimes that's overlooked too, and it probably shouldn't be in this era of patient-centered healthcare. As the patient, the consumer, becomes more in control of his or her healthcare choices, involving them in this denials process is it can have a lot of value too. Beth, how does the patient figure into this process? How do you work with the patient on denials?
Well, best case scenario in my mind, we wouldn't have to, right? It's really a tragedy to me to have to put the patient in between a payer-provider dispute on a denial. But I do think patients now more than ever are being impacted by these denials. They're starting to consider denial behavior in their benefit selection when it's an option. So I think we have to kind of play our role in that advocacy. It does impact our overturn success rates when the payer is participating in that appeal process. But of course, best case scenario, we could do that on our behalf and resolve anything before it impacts anything with the patient's access to care or barriers to timely access to that care, which is really what we want to accomplish for our patients. But when it comes down to it, when we need to pull the patient into the appeal for, post-acute type approvals, they do tend to influence the outcome of that appeal activity.
Yeah, and I would imagine as these AI tools become available to patients as well, denial rates might factor into their provider, their decision which providers to go with as well. That's where we're going with patient-centered healthcare and the idea that there's competition out there for the healthcare dollar. Okay, let's see. Well, we just talked about this a little bit. I guess to continue this conversation a little bit, is there anything in the future or any other tools or technologies or strategies that can use the patient's participation to improve the denial process? Will what you're doing now change in the future or evolve?
I think in our clearance area, we are starting to explore this a little bit where, there's strategies around pre-service patient engagement, awareness of potential financial liability, helping them understand their payment options, where at that same point, we have medical necessity reviews occurring, right, on the orders that have triggered both a need for an estimate or a financial discussion have also triggered the medical necessity and authorization process. So is there an opportunity there to align that activity and make sure that it is most meaningful for the patient, where we can not only discuss potential financial liability, but risk of denial or likelihood of the service being authorized and things like that. So I think that if we could get that data in one place, that would certainly be a great outcome for the patient, a great benefit to us as well.
Yeah, so including the patient in those proactive upstream steps, and as you say, start talking to them about everything before, as soon as possible, possibly before even the medical experience takes place. Eric, same question. Are there more strategies out there for getting the patient involved in this process?
Yeah, patient education, big thing. I think that's consistent. Anytime I've had discussions about this, it's the clearance part of things that Beth was mentioned. Making sure the patient understands their obligations, understands what an EOB is. I still think a variety of patients out there don't know what an EOB is. So I think those are things that technology can help out with. Obviously, providers have their advocate teams that really handhold throughout the process to make sure the patient understands what that billing process will be. Again, having the tools to be able to go online to view claim status from a provider standpoint, being able to track that type of thing, communicating that to the patient digitally, those types of pieces of technology can help enable some of that too. And really, the proactive communication about insurance coverage changes, if the deductibles due, using EOB type data to be able to communicate that to the patient to inform them. Do they still have a remaining deductible? If they aren't already aware of that, what that remaining deductible is. All those are things that can help navigate the patient through the entire revenue cycle, not just managing denials or financial obligation overall.
Yeah. Okay. I just want to mention we are about almost 15 minutes left in the hour. I'm surprised it's gone by quickly. I want to remind those of us in the audience that if you're interested in asking a question, please use that question box and submit it now. I will be starting to integrate some of the questions in the Q&A box into our conversation as we move forward. And this actually is kind of the wrap-up question. I do have another one after this, but we start taking a look at the future. I know it's kind of a a tricky time right now, in that there's so much going on. There's so many challenges in the healthcare sandbox. There's so many new technologies and ideas being introduced that it seems that there are changes being made every day, and it's certainly the payer part of this is in turmoil right now as well. Now, how do you see your strategies evolving? How do you think, how will things change in the future for you to reduce denials and improve payer collaboration?
Yeah, generally, I think revenue cycles have always been pretty resilient. So we're used to an evolving world of activity, payer behavior, regulation. So I think it's just important to have a strategy that is multidimensional, can be flexible, accommodates kind of where your organization stands with level of accountability and where that accountability tends to sit. I really think denial prevention and denials needs to become more part of an organization's DNA rather than something that we're trying to tackle as a crisis, and utilizing the right resources and education through physician advisory, clinical leadership, finance, so that those strategies can accommodate what comes down the pike. I think that if your strategy is too narrow, then you can be more impacted by changes in regulation, which I really hope and expect to see around denials. So making sure that your strategy could accommodate some of that could come down the pike, as well as external factors that could influence your strategy, just making sure that it is built around the capability to adjust for that.
Okay. Eric, same question. How do you see this area evolving?
Yeah, I mean, I think AI is obviously going to evolve over time. There's going to be new things that come up that's applicable to it. I think, Beth highlighted it many times. I think the big wish of everyone would be just to not have denials, not have problems with denials, to be able to predict them. It's one thing to be able to automate just the appeal process, right? But being able to predict them more frequently and more accurately, I think that's really where we're going. To leverage a huge data lake of data from a variety of different possible sources, those types of things, being able to leverage that and then powering the AI engine. I think that's the big opportunity, and that from that AI engine being able to accurately predict if there would be potentially a denial or the likelihood of a denial, to get it beforehand. Obviously, for those payers that might be more prevalent for the delay tactics, even identifying, hey, you may have risk to have a delay tactic here because all the criteria have been met, clinical documentation, prior auth, whatever. So that might identify from that list of potential delay tactics. So those are all things I think where we're going, but ultimately try to prevent them from happening from the start, for sure.
Okay. Well, I asked and everybody responded. We have plenty of questions in the Q&A queue now, so I'm going to jump into them here and grab a couple of them. I know I won't be able to get to them all, but we certainly will try to get as many as possible. Beth, you had mentioned a while back the idea of a payer scorecard. Can you share an example of a payer, or explain what a payer scorecard is?
Yeah, so we use our receivables and remit data and account data to generate certain metrics that are applicable to a payer scorecard. So we look at metrics like days to pay, days to initial denial, days to denial resolution, percentage of AR over 90, denial rates, denial write-offs, and now, as I mentioned, some of that cost to collect activity to try to measure administrative burden from a payer. So it continues to evolve every time we come up with a new metric idea or something that we think would be relevant to a payer negotiation or discussion. We talk about how we could quantify that information and have the data to support the claim that we're trying to make. So it's an ongoing collaboration between the revenue cycle team and the payer relations team, who, of course, have their own metrics that they utilize as well around rates and reimbursement, that are part of the payer scorecard as well. So we have that at the financial class level, at the payer level, and at the plan level, and do a lot of comparative analysis, of course, to see how certain metrics reflect for certain payers versus others. But I'm happy to share after the meeting maybe some examples of what some of those metrics look like, de-identified for some ideas.
Okay. Nice. This is kind of for both of you here. We talked a little bit about physician education. How has physician education helped with supplying acceptable diagnosis codes for insurance? The person asking here notes there was a fine line in what we can tell them is covered. In either one
Education
of you.
hasn't helped as much as technology, for sure, because again, that's so tricky across different payers that adopt a variety of policies around labs, especially. You can tend to target payers, for example, that utilize EvoCore, for example, and they all follow the same policy, maybe do a wider approach on particular policies, but you could educate on your highest volume and your most frequent denials. That's, of course, the start is understanding what CPT codes even and what orders are resulting in these denials. But the most success that we've had is alerting at the point of ordering those labs. So if I'm going to order this lab for this patient, the lab is the CPT code, and they have this payer that has this policy that's applicable to that CPT code, building that within the order to say, hey, here are the acceptable diagnosis codes for this order. The one that you ordered is not considered medically necessary for this policy. Do you have a qualifying diagnosis code, or can you provide some support to help us appeal when a denial is to occur?
Okay. Eric, same question.
I think Beth answered that. I think this specifically around this. I mean, obviously, when we provide the technology, the reporting, analytics, all that behind the scenes, that helps pinpoint some of those opportunities for physician education, certainly. But I think Beth answered that.
Okay. Okay, let me try this. Here's another one for Beth. How do you figure out your cost to collect for your denials?
So the easy way is if you have a particular user set, user template, or user base that's fully dedicated to denials, then you can quantify that expense pretty easily around those resources. Same with any vendor costs that you have where those vendors are fully dedicated to denials. But we have to configure our system and the data around a touch to associate whether that touch is associated with a denial or not. So the types of activities that all of our staff perform on an account indicate to us whether that touch is associated with denial resolution or denial action. And we quantify each touch based on user cost. But it's really easier to target a higher level cost to collect on teams that are working these or vendors that are working these, where you can apply that cost to your overturn success payments to see especially what types of denials you have the highest overturn success rate, which of course would have the lowest cost to collect, and which population of denials have a high cost with very little overturn success or reimbursement outcome, and then make the decision on whether those efforts are being dedicated to the right population of denial.
I see. Okay, good. Another question here is, what is the best way to create overturn metrics and assess overturn metrics when you're not always getting formal correspondence from payers, or when something is overturned? How do you deal with a payer that's kind of reticent about getting in touch with you?
Oh, that's tricky. So we have the data around the history of a denial. So when a denial was created and when a denial was resolved, and what is the resolution status of that. So did it result in a payment, and pulling that payment data? Did it result in a write-off pulling that write-off data. So that's really the driver of the overturn. I think you're going to have that data within your system to be able to get insights into it. I wouldn't really rely on a payer, and this data can take a long time to get, right? So, denials can be under appeal for 180 days or more. So you need to try to be thoughtful too around the timeliness of your data and what is still actionable versus what is old news at that point.
Nice. Okay, we got a very active audience here. I've got a lot of questions coming in. We're within 5 minutes. I got one more question I want to ask you, and then I got a final question for myself that I want to get to as well. This last question from the audience is, what do you find is the most effective approach when it comes to getting the provider on board with documentation that will meet criteria for medical need review, or medical necessity review, prior to or even in NPR situations?
So I think that you need to help the provider understand, one, how it impacts them directly. I don't know if there are any type of incentive arrangements that this could impact. That certainly helps, but even more so, help the provider understand how this impacts the patient. I think if there is a potential that the patient's stuck with a bill, the provider does not want that to be the case. And, we have received, as I said, very varying levels of engagement from these providers on how they want to contribute to the success of a denial. But I think when we pull the patient into the mix, helping them understand how it impacts them, barriers to care or financial impact, then that really speaks volumes to them. And just trying to involve them and engage them in making a difference for the patient is what is going to bring them to the table. It's not always, sometimes, as I've heard, what makes a biller's job easier, which is sometimes their perception.
Yes, yeah. Okay, I've got this last question for myself, really. I kind of want to try to summarize what we've had here for the past hour. I want you, if you can, to kind of give us the top 3 or 5 recommendations for a rev cycle department to improve denials management based on what we talked about today. What should another hospital or health system be doing right now to make this process better?
I would say understand your data and make your data work for you, and make sure that your processes generate the data that will give you the insights to understand your challenges and opportunities. Reaching out beyond your revenue cycle to get the people at the table that can help make a difference, whether that's through physicians or physician advisory, payer relations, and even legal has been a great player in the success of our overturns, where these go through the escalation process and ultimately land with demand letters or legal disputes. They have been very successful in helping us and supporting us from that perspective. So I think data and having the right people at the table are critical, even prior to exploring technology solutions, right? Everything Revenue Cycle does anymore is around what technology solutions can help support us in accomplishing that. So that, of course, plays a role here. But if you don't have the operations, the people, the infrastructure to make that technology work for you, you're not going to be ready for it.
Nice. Okay. All righty. Eric, same. You want to add, any other points or suggestions for health systems?
Yeah, I think what Beth was saying, obviously technology, I've come from the technology side, right? But that really comes down to trusting your data. If the data source is trusted and it's been audited, the whole organization trusts it. Having the end-to-end data throughout the revenue cycle, obviously from front end as well as patient payments. If you're able to leverage that data and trust that data, I think that's the biggest thing from a technology standpoint. That then powers AI and other things as well. But I think that's the main thing I'd add at the end of it.
Yeah. Okay. This has been fantastic. Thank you very much, the both of you. You've been rock stars today for this conversation. It's been a very eventful, very entertaining and educational hour that we've had here. That's all the time we have. In closing, please note that next week's program will cover the winning edge for promoting physician wellness. A live clickable link will appear at the close of this program, taking you to our registration page for the event. Remember to follow along all week as we cover the topic of defeating denials. And I mentioned there'll be a story on this tomorrow. We'll have the video on YouTube by Friday. So there's a lot more to be said about this. And that'll be on our website, healthleadersmedia.com. I want to thank our panelists once again for an excellent discussion. Beth and Eric, thank you very, very much. And our sponsor, Waystar. Finally, thank you to our audience for participating. We hope you enjoyed today's program and look forward to seeing you next week and in following weeks. Next week on Promoting Physician Wellness and the following weeks for our other events as well. Thank you very much.